Recognizing a serious skin reaction is a critical skill, as some rashes can signal a true medical emergency. While many are benign, others can be the first sign of a life-threatening systemic process. Understanding the key features that distinguish these conditions is essential for timely and appropriate care. Let's begin with one of the most frequently encountered reactions, the morbilliform drug eruption. Often referred to as a maculopapular rash, it presents with red macules and papules that merge into patches and plaques that turn white with pressure. This rash typically appears 4 to 14 days after a patient starts a new medication. Intense itchiness is common, but importantly, the patient usually does not have a fever and the rash does not involve mucous membranes. Treatment is straightforward, focusing on comfort with topical steroids like 0.1% triamcinolone cream and antihistamines. The condition generally resolves on its own over 1 to 2 weeks. But not all skin reactions are simple rashes. Some indicate inflammation of the blood vessels themselves, a condition known as leukocytoclastic vasculitis, or LCV. The hallmark of LCV is palpable purpura, raised purplish spots that do not blanch when pressed. These lesions can sometimes progress to form blisters, ulcers, or even areas of necrosis. LCV most commonly appears on the lower legs, feet, back, and buttocks. It has a wide range of potential triggers, including infections like COVID-19 and hepatitis, autoimmune diseases such as lupus, malignancies, and a diverse array of drugs. Another condition that can present dramatically and quickly is acute generalized xanthematous pustulosis, or AGEP. This is a rapid onset condition where patients develop numerous, tiny, uniform pustules on a red base. This typically occurs within 2 days to 2 weeks of an inciting event. Unlike a simple drug rash, patients with AGP almost always have persistent high fevers and often complain of burning and itching. The rash frequently starts on the face and in skin folds. While many drugs can cause it, penicillins and cephalosporins are the most commonly implicated. AGP is distinguished from another serious reaction, DRESS syndrome, by the clear presence of pustules and the absence of atypical lymphocytes on a blood smear. Management involves stopping the offending drug and providing supportive care with acetaminophen and topical steroids. Sometimes, the trigger for a skin reaction isn't just a medication, but a combination of a drug and an environmental factor. This is the case with phototoxic drug reactions, which essentially present as an exaggerated sunburn. Patients develop redness, swelling, and even blistering in sun-exposed areas. A unique insight here is that UVA light penetrates window glass, so patients might not even realize they've had significant sun exposure. Common medications associated with this reaction include NSAIDs, tetracyclines, hydrochlorothiazide, and voriconazole. While some reactions are widespread, others present with very distinct and recognizable patterns. Erythema multiforme is famous for its classic targetoid lesions, which have 3 distinct color zones. These lesions are most commonly found on the hands and feet. The crucial point to remember is that 90% of adult cases are attributable to the herpes simplex virus, or HSV. The rash can appear before or at the same time as the viral infection. Because the underlying cause is often viral, steroids are generally avoided to prevent a potential rebound of the condition. The key diagnosis to distinguish it from is Stevens-Johnson syndrome. From localized target lesions, we now move to a condition defined by its overwhelming scope, known as erythroderma. This is an end-stage inflammatory reaction characterized by redness and scaling that affects over 90% of the body surface area. Its onset can vary from days to months. Erythroderma is a true emergency due to its severe systemic complications. These can include hair loss, nail dystrophy, peripheral edema, and lymphadenopathy. Most critically, the widespread vasodilation can lead to high-output heart failure and a dangerous inability to regulate body temperature. It's common in patients with pre-existing skin conditions like psoriasis or eczema, or a type of lymphoma called Sézary syndrome. The medication allopurinol is also a frequent offender. These patients require immediate hospitalization for IV fluids, electrolyte correction, and temperature regulation. Another severe systemic reaction that can be deceptive in its initial presentation is DRESS syndrome, which stands for drug rash with eosinophilia and systemic symptoms. A key feature of DRESS is its delayed onset, typically appearing 2 to 8 weeks after a new drug is started. It often begins as a morbilliform eruption, but is accompanied by fever and a high eosinophil count. Patients commonly develop painless, swollen lymph nodes. The real danger of DRESS lies in its potential for multi-organ involvement, often causing a severe hepatitis. High-risk drugs include anti-epileptics and allopurinol. The Reggie-Scar score is a tool used to help make the diagnosis. Treatment is serious, requiring systemic steroids that must be tapered very slowly over weeks to months to prevent a relapse. Finally, we arrive at the ultimate dermatologic emergency, a condition that demands immediate and intensive care: Stevens-Johnson syndrome and toxic epidermal necrosis, or SJS-10. This is a severe mucocutaneous disease caused by widespread death of skin cells, a process known as keratinocyte apoptosis. The absolute hallmark symptom is significant skin pain, which is then followed by blistering and detachment of the epidermis. The diagnosis is classified by the amount of body surface area affected. SJS involves less than 10%, while 10 involves greater than 30%. Anything in between is considered SJS-10 overlap. Fever and malaise are common, and mucosal involvement is nearly universal, affecting the oral, ocular, and genital tracts. This can lead to devastating long-term complications like blindness and strictures. The Scorton scale is used to predict mortality. Common culprits include anticonvulsants, allopurinol, and sulfa antibiotics. The mainstay of treatment is aggressive supportive care, ideally in a burn unit or ICU, while additional therapies like IVIG or TNF-alpha inhibitors remain controversial.